Hello, everyone. My name is Dr. Vladimir Barayev, general pediatrician specializing in autism for children. And this is Autism Demystified. This is the show where we talk about all topics related to autism care, particularly for children. And today we have a very wonderful and special guest with us, a child and adolescent psychiatrist, Dr. Shivana Naidoo. And I would like to start out by reading this beautiful biography intro that we have prepared for you all. Dr. Shivana Naidoo, MD, is a board certified child and adolescent psychiatrist. She lives in Arizona, but she grew up in Queens and remains a New Yorker at heart. Queens, New York, God bless you. She is an attending at a Bradley Reach Virtual PhD program and is an assistant professor at Brown Medical School. Her private practice, Do Better MD, aims to help her patients to know better, to do better, to feel better. And her amazing podcast, Thinking It Through with Dr. Naidoo, child psychiatrist, helps empower patients and parents. Dr. Naidoo, welcome to the show.
Thank you so much, Dr. Vlad, for having me.
Oh, it is absolutely a wonderful blessing and a privilege to have you here today. It is not easy to find time to sit down and speak with a child psychiatrist. So I do not take any second that you have given us for granted. And we're going to jump right into the topic for the day. And that is talking about autism and childhood anxiety. So the first question for you today is, I get anxious sometimes. Things make me feel nervous. Well, what's the difference between feeling anxious and having an anxiety disorder?
So that's a fantastic question. And as we know, for those of us listening in who are parents of youth or adults with autism, it's a little tricky, right? It's a little tricky because a lot of things, just by virtue of having autism, can look like anxiety because life is more stressful for kids with anxiety. Compared to kids that do not have autism, the range of those kids who have anxiety is somewhere between like 1 in 12 to 1 in 4. So about 25% max in the general population of kid without ASD. But those with autism, those ranges are pretty high. Some studies as high as 70%, 75% of kids with autism have some experience of an anxiety. And anxiety is different than anxiety disorder, right? So in psychiatry and in peds and in medicine, you can have a cold, right? You can have symptoms of a fever. You can have symptoms of an ache or pain. But is it at the level to cause dysfunction? It's got to cause dysfunction to really be a disorder. So when I ask parents to think about symptoms, like let's say you have a youth and they get really anxious when the toilet flushes. Okay, typical thing for a kid with autism. If that is, we have to track or find, this is an acronym that I use, the symptom. So F stands for frequency. How often is it happening? I, how intense is the disruption or the anxiety because the toilet is flushing? N is the number of times it happens. Like if the toilet is flushed, your youth with autism hears it, are they dysregulated and get like multiple outbursts with that one thing? Or is it kind of mild and just a one-time thing versus really spiraling? And then D is the most important part in this FIND acronym. That's dysfunction. Is it so bad that they don't go anywhere because there might be a toilet there? Is it so bad that they avoid school because there's toilets? Are they avoiding toilets at school and then have accidents, right? If it's at that level of dysfunctionality, then it may fit the criteria for disorder. But as you know, Dr. Vlad, you see parents with kids with autism. I see them. You guys are exceptional parents. Parents of kids with autism, they have so much heart. They have so much attentiveness. They're so attuned to their child. So the baseline, where you know your child is at a baseline with their anxiety, and then the difference between that baseline and something happening, that also is very helpful because we know, depending on the severity of spectrum, that youth may not be able to express it, right? We have to observe their actions to tell, is this anxiety? Is this just a reaction to a change? Is this a disorder? Is this impactful and impairing? Or is this something that your youth can handle and just keep at it?
Yeah, so the level of dysfunction is what really differentiates it. If it's just a feeling of one time versus it's impacting the way that you're living at home, school, with your family, with your friends, etc., etc., etc. That's really powerful. I thank you so much for that. So tell me now. Uh, And the other thing, the other point that you brought up that I really want to, so I don't like kissing up to parents of children on the autism spectrum. So I'm going to tell you guys the truth. You are wonderful and amazing, by the way. I'm not kissing up to you, just stating the facts here. The way I know you're amazing is because you have gone through so many of the tantrums, the breakdowns, the aggression for so long that you're not phased by it. It's not like something that causes you to get out of rhythm at a certain point. You just become like this finely tuned, trained athlete that you know how to, this is what my child needs at this moment. This is how I'm going to respond. I'm not going to lose my mind and act like my hair is on fire. I'm just going to just go into it and handle the situation. And then we move on and getting forward. It's like, it's just an amazing thing to see how parents, kids on the spectrum, that like professional athlete level of training in terms of keeping their cool. You want to see someone who keeps their cool. That's where you want to go. So let's talk about behaviors. This is one thing that you mentioned. So, and I just want to highlight the other thing that you said, which was particularly for kids who are nonverbal. So behavior, I'm going to sound like a psychiatrist, even though I'm not, so don't even pretend like I am. Okay. Behavior is a universal language. Everyone understands behavior. Even when they can't speak, you could still act and show the world what's going on inside of you. The behavior may not match exactly what you're trying to say. It may seem a little atypical or odd, but it's still a form of communication. It's the form of communication that everyone has. So on that point, how does anxiety show up differently in kids who are on the spectrum versus children who are neurotypical?
Yeah, I think that your comment about behavior is so important because, as we know, with parents of kids on the spectrum, I love your analogy of a high performing athlete, right? They're tuned in, they're focused. I also like the analogy of a scientist, right? We have to be kind of curious and really strong observers of our kids. We should do that anyway, right? But I think parents of kids with autism are more fine tuned to really observing and interpreting what they see in their child, which is the behavior. So, anxiety does show up a little bit differently for kids with autism because their ability to express their emotions, their verbal ability is different, as well as their perception of social interactions. And we also know with kids on the spectrum, they have preferred activities. So those preferred activities may impact and influence their expression of anxiety, as well as be a cause of anxiety. For example, some kids who are on the spectrum may really love the garbage man. And then if it's Christmas Day and garbage is due to be picked up, but they don't come that day, that might cause some anxiety for that youth. Or they may have anticipatory anxiety because they're worried that this one day the garbage truck will not come. And we know that's their preferred thing to watch for. Kids on the spectrum also might be more sensitive to anxiety-provoking situations that affect the sensory perception. So let's say grandma bought them a sweater and that sweater is itchy. They may then have some anxiety or an anxiety response to wearing sweaters in general. Or let's say flies, hearing a fly. They have one interaction with a fly or a bee, and now they really have heightened anxiety for this experience of having a fly or a bee around them. Kids can also, of course, because of the difficulty with adaptation to different environments, whenever youth on the spectrum go from place to place or it's something unplanned, even when it's planned, right? They may have some, again, anxiety response going there, sitting in the car to get there. Even when they arrive at that new venue, they may need some time to settle and have some anxious experiences and behaviors because of that. So these are some specific examples where youth on the spectrum are more likely to have anxiety symptoms. And all youth really under the age of 6 can have some separation anxiety. They may have some difficulty with being away from their parents or away from their identified guardian or preferred object. But in spectrum kids, this may persist for a period of time. long after they are, when it's less age appropriate, like age 14 or 16. They should be able to, a more neurotypical youth might be able to tolerate their parent being in another room. But depending on the situation, some kids on the spectrum may not. They may still have a hard time being away from their preferred objects or preferred people. So these are some ways that I think kids on the spectrum are more prone to having some anxiety symptoms. And we know because most youth with the spectrum have some kind of repetitive behavior that tends to be a STEM behavior. They can have more of that when they feel dysregulated. You know, kids on the spectrum tend to have a dysregulated HPA axis, the hypothalamic pituitary adrenal axis, which is our brain-body connection for releasing cortisol, which is our main stress hormone. So because that axis may be a bit dysregulated in these kids, they may be super responsive to cortisol. So their experience of stress is going to be heightened compared to another youth that doesn't have autism. So these kids may be rocking more. These kids may start skin picking more. These kids may start scratching or head banging or slapping themselves, you know, behaviors, quote unquote behaviors that maybe as the guardian, you know, but as the teacher may cause you a lot of anxiety and stress. And I think that's another component of anxiety that I wish we could educate more paraprofessionals and teachers about, because of course we understand it's hard to see our children rocking excessively or seeming to hurt themselves, but we know our kid and we know that's just their way of calming down. You know, so the behavior can be interpreted very differently based on the person observing that behavior.
Wow, that's a very stoic perspective, is that like we may not always be able to control or understand where a child's anxiety is coming from or the type of anxiety response they may have, but we do still have control over how we respond to their anxiety. And that is where we have to exert our controls on ourselves first and foremost. It's really, really powerful. I love hearing that. How about, you mentioned something that made me think of something completely different. So you said the HPA axis. Can you speak a little bit about the differences in the activation of the sympathetic and parasympathetic nervous system for kids on the spectrum? Like, do they also have a heightened levels of sympathetic activation as well?
Yeah, so when we think about fight or flight, right, which is kind of a simplistic response to stress, which is sympathetic, and then parasympathetic, which we like to think about as reducing stress, but really actually it's more about reducing the input for stress. So it's not quite opposite, but with the sympathetic, absolutely, youth on the spectrum are more likely to do a fight, a freeze, or a flight. And as you probably know, we see on the news very often when youth in school get stressed, have a response, and then they leave school and they elope. And that's because they are really responding to that flight, and their sympathetics are going haywire because they're trying to be safe. And I think this is another way where sometimes, for example, if youth are feeling that way and trying to escape because their parasympathetics are on fire, their stress response is on fire, people might try to calm them down, put them in a cozy corner or a quiet room, but that may result in a tussle, right? There might be a time where these kids are not really ready to self-regulate. They need that space to do it on their own and may not be responsive to other adults kind of getting them into that safe place, and things can sometimes become aggressive, right? And that interpreted by different people as, you know, bad kid, difficult kid, when really this is a kid who's just excessively stressed and really finding a way to cope. You know, so that primal response is very, very hyper-reactive and sensitive in kids with autism.
So they're basically responding the way that we would expect them to respond given their perspective on the world. Like if you had that same perspective, you would respond the same way too.
Well, and also it's harder for them to stop themselves and think it through, right? Depending on the level of that child's functioning, but also on their ability to recognize. You have in order to self-regulate, you have to first acknowledge that you're out of control. And sometimes kids on the spectrum can't quite get that at an age-appropriate level. So they need to learn that, and that's the responsibility of parents, ABA therapists, psychiatrists, pediatricians, right? We're all trying to get them to that self-awareness, but they may not be able to. So their first response is, let me get to somewhere safe. Oftentimes, these are youth, when they leave school or they leave a situation, they are trying to get somewhere safe. They're trying to escape. They're trying to get to their parents. They're trying to get to a quiet place they know in their school. So it's really important that if you have a youth with autism, when they are calm, these are kids that are prone to become aggressive because of anxiety and stress responses. When they're calm, walk them to the quiet room. Get that to be a habit beforehand, because maybe these are kids that when they are hyper stressed, they can get there on their own versus really not know where to go. And, as you know, for parents with youth with autism, we try to anticipate everything, right? We try to be ahead of the game. We try to pre-prepare, let our kids know this is the changes that are going to happen. We prime them because we anticipate it causing stress and anxiety for them. But we have to do that when they're in a calm space and receptive to learning that skill. Once they get up here and that like reptilian brain is activated, that flight or fright response, they will not be able to access that calm space to really decide. They're just going to react.
Okay. The next question I have for you is relating to treatment. So the two components for management of anxiety. First, if you could please inform our audience and educate us about the non-medication approaches to helping children with autism and their anxiety. And then we can touch upon afterwards, have a discussion about what role medications play.
Absolutely. So with kids on the spectrum, depending again how severely on the spectrum they are. So let me talk about the least on the spectrum, right? Because there are kids with very high functioning autism, yet autism still impacts them. Meaning they can speak, they can express their emotions, they seem to want to connect to other kids, and yet they still are diagnosed with autism. These kinds of kids who seem to be able to really have a back and forth conversation, understand or want to understand their emotions and be at that level, you could try something like CBT or cognitive behavioral therapy. That's a specific type of therapy where we teach adults and youth that their thoughts, their feelings, and their actions are all connected. And we try to work on that triangle, which has a bi-directional relationship for each. Your thoughts, your feelings, and your actions to try to impact the action and the feeling of anxiety. So that is kind of the gold standard when it comes to anxiety. And depending on what may be provoking the anxiety, you may have something like an exposure ladder. So a hierarchy, like let's say this child is scared of flies, okay? And they have the cognitive ability to talk and engage with you. So maybe the highest thing is being at a picnic with a bowl of watermelon that you know will attract flies, right? That would be at the very top. You're not going to just throw them in there, right, to expose them. Maybe you're going to start with just having them see a picture of a fly without the sound. Maybe you start with the sound and not the picture. Maybe you just start with the word fly. Maybe that itself is going to be too activating for them. So you create a ladder with increased gradients of the severity of the exposure to get that child to kind of learn the responses, practice it in a lower stress setting. So that's kind of CBT, and that would be a gold standard. But depending on the child's cognitive abilities, they may not be able to participate in that. So what you need to also be able to do is think about the gold standard of ABA. So in applied behavioral analysis, this is where we have experts come into the home and help youth kind of do a functional chain analysis of why and how stress is triggered and what were the things upstream that we might be able to control in their environment or in their home or give the youth easy access to help them do better. So with applied behavioral analysis, there's the action plan of what we can put in place to really help their actions and their environment to help reduce the anxiety upstream. But having someone to observe that and really put that together with what's practical in the life of that child is really important too. And sometimes that's why it's helpful to have these discussions with your pediatrician or a child psychiatrist, because when you're a parent, you're in the thick of things. Although you're a fantastic observer, it might be hard to see certain things. You may not realize them unless you have someone giving you an outside perspective to give you the perspective you need to actually make the change you need. So that is non-pharmacologic, non-medication interventions. And there is some evidence that some vitamins like magnesium can be very helpful for an anxiety regulation. So that might be a supplement, which is not a medication. But we know with supplements, they are not monitored by the government. They're not FDA regulated. So there's varying challenges with using vitamins. Vitamins are not like a replacement for medication. But as we know, if we want to try to avoid medications in our children, we think of all the possible options. And of course, anticipatory guidance, right? Knowing and anticipating what are some times that you think can really bring up anxiety for your child, and being pre-prepared and letting your child know about them in advance, and like getting that anxiety preparedness, so that when they're faced with that challenge, they might be easier able to manage it on their own.
Okay. And now from the standpoint of, you have a child that either refuses to participate in cognitive behavioral therapy, or they're too anxious to participate in cognitive behavioral therapy, or they're not verbal enough to participate in CBT, cognitive behavioral therapy. And families ask you, well, now what do we do now? Where does the medication play a role in this?
So in terms of medications, in youth, there really are only 3 medications that are FDA approved for anxiety and depression in kids under the age of 18. Those medications fall in the category of SSRIs, or selective serotonin reuptake inhibitors, also known as Prozac or fluoxetine, Zoloft or sertraline, and Lexapro or escitalopram. So these 3 medications are typically used. Of these 3, we think of Zoloft mainly for anxiety, though all of them can be used for anxiety and obsessive compulsive disorder, which sometimes can also happen with kids on the spectrum, which may be hard to differentiate from their perseverative repetitive behaviors, but that comorbidity is there too. So these 3 medications are often used when youth have anxiety, and it just depends on the responsiveness of that child. But I will say, for the variety of kids that I've taken care of who are in the non-verbal component or less verbal component, it is really interesting to see how very often a very small dose of these SSRIs can make a dramatic impact in their tolerance for stress. And sometimes as a doctor, seeing them once a month, once every 2 weeks, once every 3 months, I may not see it because I know them coming to my office and seeing me causes them stress. So they are not in a calm place to see me in my office, right? Most autistic
I dress
kids
like
are
this.
not. But the parents see it. So that's why it's so important to gather that collateral from the parents, because they will say, I know they look the same, but now they can tolerate the fly being there at the picnic. Now they can go to school and use the restroom, or at least be okay hearing the restroom is there and hearing the toilets get flushed. So these are the kinds of things that really parents can see as dramatic improvements, sometimes with just a very small amount. But in general, you want to make sure that if a medication is started, that you are being monitored very closely by your pediatrician, your nurse practitioner, your primary care provider, or your psychiatrist, and that any medication that is used could have side effects. We want to watch for things like irritability, increased anger or outbursts. Some kids can have increased tics, and some kids even can get a little bit more depressed. So we want to make sure, if you have to get to that level of trying a medication, that you are monitored very closely, and that you as the parent are also really having an extra eye on your child to make sure if we start a medication, it is helpful and not harmful.
Absolutely, absolutely. You mentioned obsessive compulsive disorder, and what's the definition of obsessive compulsive disorder, or OCD, for families who are not aware, and what tips or tricks do you use to determine if a child on the spectrum also has OCD?
So that's a really hard one, to be honest, because I think that with OCD, O stands for obsessions, typically a thought obsession. So you're thinking about something over and over again. And we know kids on the spectrum tend to perseverate and think about things over and over again. The thing with these obsessions is that these are obsessions that cause stress for the youth. So they are thinking about like the end of the world ending, an apocalypse. That's causing them a lot of stress. Mm-hmm. Versus a youth who might think about fire engines and the loud sounds of the fire engines and talk about it, but they don't get stressed. They actually enjoy the sound of the fire engine, even though it like brings up my anxiety. For that youth, it's calming, right? So ego dystonic is OCD, where they're obsessing over a thought and it's causing stress, ego dystonic. Whereas for an autistic youth who has an obsession that they enjoy, that's ego syntonic. They're obsessing, but it is actually serving as a regulatory function and actually soothing for them. C stands for compulsion. So when we think about OCD, you can have mental compulsions where you're thinking something a certain number of times, or physical compulsions, where I think that's where, social media capitalizes and you see youth doing certain things that seem a little bit absurd, but that physical compulsion helps soothe the dysregulation from the thought obsession. So it's almost like a compensation for their thoughts. That's OCD. And then the D, again, is disorder. So it has to cause at least 1 hour or more of impairment in your life to be OCD. But for kids on the spectrum, when they have an obsessive thought, we have to watch for, again, is it self-soothing or is it stress-inducing? And when they have an action like rocking, I can see how some parents might think rocking or ordering their cars a certain way might be a compulsion. And in some ways, it is. It is some form of compulsion on the part of that youth. But this is more of the pattern of the repetitive behaviors and the stereotypies that come with autism versus being OCD. So if you have a youth who is overthinking in an obsessive way and it's causing stress, and they are doing things that are also causing them stress, but trying to help them from that stress, that might be a time where we think about OCD. And with OCD, it is under the spectrum of anxiety. So when we think about anxiety disorders from psychiatry, we're thinking of generalized anxiety, separation anxiety, OCD, a variety of specific phobias. But with anxiety, really, it's a fancy name for stress, excessive stress, right? So we have to always think about that lens of, is this issue causing stress or not? And I will say it's pretty tricky. I have taken care of a couple of kids with both anxiety. Almost always they have a general anxiety and an OCD and autism and ADHD. Like it's always everything all at once, right? I think everything everywhere all at once is what it is. But I think we want to get at, is it causing distress? Is it something that is really trying to compensate for some kind of distress? And is it impairing their life, or is it temporary and they seem to be getting by?
And there are some families that may have heard on social media that when you see all of these things at once, and I'm really happy that you have you here with all your experience in treating kids, the families automatically think, oh, this must be pandas. This is the only that's the only diagnosis they have. All they got is pandas.
Right.
And if you could please speak to, it's extremely far more likely that they have all these other conditions, have nothing to do with pandas, than it is that they actually have a pandas diagnosis. So I want to hear your thoughts on that.
Yeah, so I think, the challenge with mental health in general is that we always want to have a reason, right? And when we see our child suffering, it is really hard to think that this may just be part of their natural progression of life. We want to find the answer for why our child is going through such a hard time. So it is a much easier acceptance, I think, as a parent to say, X caused this. They had strep. They had a disorder that is medical. And once this illness goes down, once that inflammation goes down, this will go away. I find this more common for OCD than for autism. I have a lot of kids who come to me because they have pandas or think they have pandas, and their symptom, their behavior is OCD. And sometimes it does ring true, but I think that I also think, I'm not trying to dismiss pandas, but I also think that there's a lot more that we as medical professionals need to learn in terms of understanding the functions and physiological manifestations of medical conditions. I think there are lots of psychiatric or mental health sequela of medical problems. So I do think pandas is one example of that. The problem with pandas is that it's 1, hard to detect, 2, hard to treat, and 3, doesn't always respond in a way that is a cure, because that's the other thing. We want to find the reason for why our kid is suffering, as well as how can we fix it? How can we make our child happy again, back to like little old, our beautiful child that had no problems before. So I think that it can offer this false promise in the same way that I think sometimes psychiatric medications can do, right? I'm a psychiatrist, I give meds all the time, but this is the autism community. Just because you're on risperidone and Abilify doesn't mean it's going to fix everything. Doesn't mean it's going to be a panacea of getting your child to function as if they don't have autism. So I think there's a lot more for us to learn. I think if you as a parent are concerned, there could be a medical issue that's going on that has prompted symptoms of whatever it is, autism, OCD, anxiety. It is your right to investigate. Absolutely do so. And make sure that you know who you're talking to. The credentials, the experience that person has makes a big impact on the kind of care you're getting. You should always first, in my humble opinion, go to your trusted pediatrician because they know you, they've seen your child before, and they're not going to steer you in a way that will hurt your child. They always have your child's best interest at heart. So if you see a pediatrician or a psychiatrist or some mental health care professional or some social media guru and we're saying all this stuff, fact check with Dr. Vlad. Go back to your pediatrician and ask them and see what they think, because they're going to go with what's evidence-based. They're going to go with what works for your child because every child is different. And I think that if they were to tell you, I think that it's worth investigating for pandas, go right ahead, right? They will support that. But they also can see things beyond what we know as parents. And we have to, I think it's, if you find a pediatrician you trust, hold on to them. I hold on to my pediatrician. I know I don't want to see anybody else, just that pediatrician that I love and, for my kids, because I really value their experience. And I hope that, I know it's a different time that we live in, but I really hope that people continue to turn to their pediatricians for that valued, trusted advice, because there's so many other opinions out there, but it's you, Dr. Vlad, that we need to listen to.
What a compliment. Oh my God. I feel really warm on the inside and gooey like a melted lava cake right now. On that note, I want to thank Dr. Naidoo for sharing her wisdom, her experience, her insights. And did you guys hear this, doctor? She can talk for ages and days and years nonstop because she has just so much knowledge in her brain. It's just like waiting to burst out of her from all the years of training and studying and learning and most importantly, practicing and understanding the context of everything she's doing and how it applies to real life, not theoretical stuff, but how it actually applies to the person in front of her. Awesome. Awesome. Just so powerful. I got goosebumps. Hold on. Yes, I have goosebumps on my goosebumps. So Dr. Naidoo, please share with our audience how they can learn more from your wisdom and find you on this beautiful web of the internet that we call online.
Well, I have a podcast called Thinking It Through with Dr. Naidoo, child psychiatrist. You know, April is Autism Awareness Month, and for March, I had Dr. Vlad's podcast episodes with me, so please take a look at that and listen in. I'm sure you've heard a lot from him, but he also is a wealth of information, and I was so grateful to have his time. So on that podcast, the goal of that podcast is to give education that's free to parents and youth dealing with mental health care challenges, because again, the information we get from different people affects what is being shared. And my hope is that I can spread that knowledge so that you can find the best mental health care possible for your child. So that's the best way. I do have Dr. Shivana Naidoo on my Instagram handle. And I also am on Facebook, but really my podcast is the best way to take a listen. I also am licensed in New York and in various states. So my practice is telehealth right now, my private practice, but I am accepting new patients. So if you are interested in working with me as a psychiatrist, alongside with Dr. Vlad, your trusted pediatrician, don't get rid of your pediatrician, right? Keep them. But if you need a psychiatrist too, I'm here. I'm happy to work with you. And you can email me at dobettermd@gmail.com.
Thank you so much, Dr. Naidoo. And for all the parents living in New York State, as you've heard, Dr. Naidoo is available. She's licensed in New York State for telehealth visits. And I am, once again, Dr. Vladimir Barayev, help families navigate autism with confidence. If you'd like to contact my office for a consultation in person here in New York, our office number is 917-819-5056. That is all we have for the show today. And take care, everybody.